And interestingly, he used a cystoscope, which is actually something which is used to visualize the bladder, to try and visualize the abdomen. And he was doing research on controlling intra-abdominal bleeding by increasing the intra-abdominal pressure. There are two other prominent names that you should be familiar with. Dr. Raoul Palmer. He was a French gynecologist, again, who worked in infertility and an early pioneer in the development of laparoscopy in the mid 20th century. And Dr. Kurt Sem. He was another gynecologist who dealt in infertility, and we owe to Dr. Kurt Sem the development of many instruments, and he was very progressive in his approach to modern operative laparoscopy. He was promoting doing a lot of operative work. Before him, most of it was just a diagnostic procedure. Dr. Raoul Palmer worked so much that we have a point called the Palmer point as a point of entry into the abdomen by his name. However, visualization continued to be a problem. Matlab, only the surgeon could see inside the abdomen, but his assistant could not. So we came up in this image, you can see a monitor. This monitor, when it came, the surgeon and the assistants could all see inside the abdomen. And then there was a rapid progression in the field of operative laparoscopy. So I'll go back. There's three names you will have to remember: Dr. George Kelling, Dr. Raoul Palmer, Dr. Kurt Sem. So what are the indications for laparoscopy? Diagnostic laparoscopy, tubal sterilization, lysis of additions, treatment of endometriosis, treating ectopic pregnancies, ovarian cystectomy, myomectomy, and hysterectomy. Uh, what is tubal sterilization? Is anybody able to answer? What is tubal sterilization? आपको स्लाइड दिख रही है? हाँ?
No, ma'am, slide not visible.
No, I wanted to hear somebody speak. So I stopped sharing the slide. So one of you, could you please tell me what you understand by tubal sterilization? Do you have any idea of what it is? Yes or no? What do you understand by the word additions? Adhesion. What do you understand by the word addition? I know you're a very junior class, but have you heard of the word sterilization or addition before? कहाँ कैसे चैट दिखाई देगी? Okay, okay, okay. Okay, good, Nancy. You've answered cutting and ligating fallopian tube. What do you understand by the word additions? Can you see my slides? Fibrous bands. Yes, Jatin? Yes, Arun, what do you understand by the word addition? They are fibrous bands which are at places where the tissue should not be adhered to each other. What do you understand by the word endometriosis? Endometriosis? What do you understand by endometriosis? So, like somebody pointed out correctly, tuber sterilization is when we cut the tubes either partly or completely, and we that helps in the woman to not conceive in the future. What are additions? The additions are tissues becoming adherent to each other where they should not be. So the tubes are usually a free structure. So if they get adhered to the uterus or the ovaries or the pelvic wall, it distorts the anatomy of the pelvis. Uh, what is endometriosis? Endometriosis is a disease condition in which there is yes, there is endometrium present at abnormal locations outside the uterus. So the most common location of the endometrium in these conditions is the ovary. So what does it do? Endometriosis, it causes the formation of additions, and because of that, now can you see the slides? Now can you see the slide? प्रेजेंट कर दिया देखो कर दिया ये मेरे फोन पे नहीं खुल सकता क्या
ज्वाइन किया था ना मैंने
इसमें दो होता है इस पे जाओ मीट पे जाओ इसमें दो बनते हैं मेरे
चैटिंग है ना
इस पे जाओ ये वाला प्रेजेंट नाउ कर देते हैं ना यहाँ से नाउ कैन यू सी द स्लाइड्स ऐसे रहने दो दिखता रहे दूसरे बच्चे भी क्या कर रहे हैं या मेरे फोन पे मैं साइन इन कर दूं
आपके फोन से साइन इन करूं
हाँ इसमें कि भाई दूसरी मेल वो है सिंक्ड है इस फोन पे साइन आउट करना
कोई नहीं आप वहां से देख लो मैंने सेटिंग दे दी
हाँ
साइड में
ओके
काम करना था ये मैसेज आ चुका है कि हमारा जुड़ा है
Good. So, endometriosis causes a distortion of the anatomy in the pelvis and the relationship between the tubes and the ovary and the uterus. And this endometriosis is usually causing the patients to be presenting
वॉइस आ रही है ना बोलना
to be presenting with pain abdomen, infertility, dyspareunia, which is having difficulty and pain in intercourse, dyschezia, which is having pain in passing stools. What is an ectopic pregnancy? Anybody, if you have an idea what is an ectopic pregnancy? Correct, Arun. So, an ectopic pregnancy is implantation of a fetus outside an embryo outside the uterus. So, normally the fertilization occurs in the tube, and the Yes, implantation outside the uterine cavity, and it's supposed to swim from the tube, or it is pushed by the cilia of the fallopian tubes into the uterine cavity, and it's get implanted. If the tubal function is incorrect and the cilia are not working, this implantation can occur in the tube, which is the most common site of an ectopic pregnancy. Although ectopic pregnancies have been known to occur in the ovaries, they have been known to occur in the abdominal cavity, and nowadays we also have a new type of ectopic pregnancy, which is implantation over the scar. Yes, Arun, most commonly at the ampulla. Very good. So the one of the present day issues is the implantation over the scar of the previous cesarean section. So these are all kinds of ectopic pregnancy, and they need to be dealt with. So in dealing with ectopic pregnancy, especially the ovarian and tubal ectopics, we can use laparoscopy. What is ovarian cystectomy? Where you have a cyst in the ovary. So what do you think is an ovarian cyst? Anybody has any ideas? What would you say is an ovarian cyst if I ask you a definition of an ovarian cyst? It's a collection of fluid in the ovary. It can be a clear fluid, it can be a mucinous fluid, it can be chocolate colored fluid. Correct. So we have sometimes these cysts need to be removed, especially if they are more than 6 centimeters. Yes, Himanshu, chocolate cyst and endometriosis. So you have ovarian cystectomy. What is a myoma? What is a myoma? What is it's also commonly referred to as a fibroid. Yes, it's a benign tumor of the uterus, of the myometrium of the uterus. And although the most common, so yes, the most common presentation is asymptomatic. There are incidental findings on ultrasound or imaging for other reasons. Sometimes myomas need to be removed, especially in patients who are infertile or present with heavy menstrual bleeding. So then we need to do a myomectomy. So endoscopy is very, very helpful in removing a myoma. Hysterectomy, yes, Arun, bleeding. What is a hysterectomy? Correct. So yes, so hysterectomy is removing the uterus. So traditionally, removing the uterus meant cutting the woman's abdomen and taking it out, or removing it through the vagina. Correct, Himanshu. Very good, Drishti. So nowadays, in most conditions, it can be done through endoscopy, or what we also commonly refer to as laparoscopy. You will very commonly find me referring in this lecture interchangeably the words endoscopy and laparoscopy. Now I come ask you to come back to point number 1 in the indications, diagnostic laparoscopy. What do you think is diagnostic laparoscopy important for? I'll give you a hint. Uh, when I was talking about the history of development of endoscopy, I refer to a lot of yes, for diagnosis of endometriosis. I was referring to two surgeons who were basically infertility specialists for diagnosis of myoma. Yes, yes, Anubhav and lesion can not be determined on imaging. Yes, so a patient who's having infertility, they found unexplained infertility in many patients, unexplained pelvic pain. Yes, Ananya, PID, chronic pelvic pain. Yes. So diagnostic laparoscopy helps us see what if there is a problem in the uterus, in the tubes and the ovaries, and it helps us diagnose the cause of infertility. When this when the first laparoscopy was developed, it was only essentially diagnostic. Dr. Sem was the one who said that we should be able to operate and remove any additions, any ovarian cysts, anything, any additions, chocolate cysts of endometriosis, so that patients can conceive. So laparoscopy in essence developed a lot for the help of patients who are infertile. I have not mentioned one more point here. In cancers, in gynecological cancers, it helps us where there is a doubt or dilemma in the diagnosis of patients on what surgery she should undergo. A lot of surgeries for CA endometrium, where we remove the uterus, tubes, ovaries, and lymph nodes, can be attempted laparoscopically. Yes, yes, Megan. Yes, Prakriti. Ovarian tumors can be removed laparoscopically, but they are removed laparoscopically when you have a doubt whether they're frankly malignant or not. Because if there's a frankly malignant tumor, you need to open up the patient laparotomy, not laparoscopy, and take out a lot more tissue than just the ovarian cyst. So, in malignancies or when you have a doubt in the diagnosis, you can do an operative laparoscopy even in a suspected malignant or cancer patient. So these are the indications: sterilization, lysis of additions, endometriosis, ectopic pregnancies, removing ovarian cysts, removing fibroids or myomas, and hysterectomy. Yes, Arun, for staging it can be done. Very good. So what are the risk factors in a patient that can make a laparoscopy a difficult decision to be done for a patient? So anybody has any ideas what the risk factors can be? Say for example, a patient is very obese, so she has a lot of fat in the abdominal wall. Do you think that will be difficult for the surgeon to do, to operate? I'll take you back to my first slide. Can you see the image here on the first slide where I have given a title to the slide, endoscopy in gynecology? You can see that the laparoscope has had to go through the anterior abdominal wall. Now imagine that this abdominal wall has a lot of fat. Do you think it will be difficult to enter the patient's abdomen in this if she's obese? Aarti, why did you send a dot to me? You type anything? Yes, it can, Ankit. Yes, yes. Why Parag should be easier in obese as compared to open approach? Yes, in if we open up an obese patient, it is it is better for the patient that will do laparoscopy. But VUF is what? Srishti? Are you talking of psychovaginal fistulas? VVF? Okay. I'll hold on to that point that yes, in an obese patient, laparoscopy is better for the obese patient than an open surgery. But still, putting in a laparoscope will be difficult. Would you all agree with me on that? So, obesity becomes a risk factor when we are dealing with an obese patient. Now, I'll show you the list that I had. A history of prior surgery. So, a patient has undergone some surgery on the intestines, on the uterus. So, there is a reaction that the patient's body has after the surgery that causes additions to form. So, I can have a very difficult time to see, visualize the abdominal cavity or the uterus if there are additions on it. Yes. Now, the age. What do you think age has a role to do? If an elderly patient is there, then what will be the problem with the patient? Yes, Simran. Anesthesia related. I have, sorry, there's a spelling mistake on my slide. Anesthesia mein S missing hai. And complications. So, anesthesia and age of the patient. If it's a very young patient, it becomes difficult, or a very old patient, it becomes difficult to do laparoscopy. Now, I'd like to dwell upon the point number 4, anesthesia related complications. Now, how do you exactly go about doing a laparoscopy? I'll again go back to slide number 5. With the image. Now you've seen this image. There is a black thing at the top, that is the camera. It has got an optic cable behind it, and I've put in a steel instrument into the abdomen. It's putting light over the uterus. But this abdomen is normally not inflated like this. So what are we inflating it with? What do you think is the gas used inside the abdominal cavity? Correct, carbon dioxide. So I have to inflate the abdomen with carbon dioxide. So what is the cavity upper limit? It is the diaphragm. Yes. So below the diaphragm to the pelvic diaphragm, there is a space which I have inflated with carbon dioxide. Yes, you're absolutely right. Even helium was considered, but CO2 is considered far better. Now, I have inflated the abdomen, so the diaphragm will rise. Yes, if the diaphragm rises, what happens to the lungs and the heart? They get less space to expand the lungs, and the cardiac function will also be affected. Because you all know, yes, total lung capacity will decrease, and the heart will also feel a pressure because that is also limited in the same space. So you have to be concerned as an anesthetist. They are concerned when they intubate the patient, the kind of pressures they will require to maintain the lung capacity, to maintain the oxygenation in the lung, and to maintain the heart functions. So any old patient or even younger patient with a cardiac defect, or with a lung problem, or with some other airway related disease, will have a very difficult problem in undergoing laparoscopy, because the anesthesia itself becomes difficult. So when the anesthesia becomes difficult, it is better to go for a laparotomy, where we cut the abdomen open, where you can use some other means of anesthesia like spinal anesthesia, or where the heart load on the heart will not increase. Yes, Gagan. Hemodynamic instability. Nitesh, what is TOMY? Laparoscopy is done under general anesthesia. Always. So these are the risk factors. So what are the complications of this is the trocar placement image in the, can you see the patient's abdomen? You can try and identify the xiphisternum. Try to identify the lower edge of the rib cage. I'm showing you the anterior abdominal wall. Laparotomy can be done under general anesthesia, and it can be done under spinal anesthesia, Arun. But when we are doing a laparotomy, that is opening the abdomen full, giving an incision, vertical incision, we will not increase the pressure on the lung and the diaphragm. So for laparotomy, Arun, we can use general anesthesia and we can use spinal anesthesia. Both work well. Okay, so now you see this slide. This is an image of the anterior abdominal wall, and you have vessels being marked here in red. अब फिर से slide में दिख रही, I can see the slide. I have another handset over here in which I can see the slide. दिख तो रही है ना?
जी visible.
हाँ. Arun, check again. So this slide, it has an image of the patient lying down, anterior abdominal wall. The vessels are marked in red. You remember from your anatomy class? Good. Inferior epigastric artery and the superficial epigastric artery and the superficial circumflex iliac artery. Now these are the vessels that are in the anterior abdominal wall. Okay. Now where these vessels are there, you will see two lines like in a V, they're going down to meet. And these are basically the rectus abdominis muscle. Okay, and the blue points are the ones where we usually make the ports. All right, the one in the middle, there are 3 points in the middle. The second one from the top is the one is around the umbilicus, that is usually where we make the first port. Okay, once we have made the first port entry and we put in a telescope and inflate the abdomen, then only we make the other ports. So the other ports can be made under vision. So when we are making the second port, I'm going to go back to a previous slide. Just hold on to that thought. You see the other ports here? They're slightly higher. So this person has made actually three ports. Yes, one is for visualization, the others are for operating. Correct? So the one which is highest up near the surgeon, that is the fourth port. The first that is above the umbilicus, that is the one where he's putting in the light, and first he has insufflated the abdomen with carbon dioxide. Then he has made the other three ports and they are for operating. So all the other ports are made under vision of the first port which has a camera. All right. And when you're putting in the second and third ports, you trans illuminate the abdominal wall from inside and see for the vessel so you don't puncture a vessel while entering the abdominal cavity. So from this diagram, you can make out that it is very fairly easy to enter a vessel and puncture it. Also, if you go to lateral, you will be entering more towards the lateral wall of the abdomen. You will be finding plexuses of nerves when you can cause nerve injury. So that is why it is very important to know where exactly you will be placing your ports in the patient's abdomen. Okay. I talked to you about Dr. Palmer, a French infertility specialist. So 2 centimeters below the left side lower edge of the left rib cage is the point of the Palmer's entry point, where they find that patient can have a history of addition, so that is a safer point for entering into the abdominal cavity. You will less likely injure any tissues. All right, so this is an image about where you can put, where the ports are usually put in. Tina, yeah, in the lateral, it's in the. आपका phone आ रहा है. So what are the complications? So I try to find. I think you like this. You like this image that I have found to be put with the complications. It's more about people going out in the wild to take pictures. But no, it's about troubleshooting the possible complications that you can have in the laparoscopy. All right. So, gas embolism. What do you think is a gas embolism? It's just that this gas escaping, getting into a vessel, getting into the system. You can enter a major vessel retroperitoneally. Now, how does that happen? I'll go back again to slide number 1. You see the direction of that port going diagonally backwards. Now, when you are entering the abdominal cavity, you can directly actually hit the aorta at the point where it is bifurcating, and there is a median sacral artery that arises there. And it is a known complication that suddenly, if you enter the abdomen, you're in, especially in a thin patient, your trocar can directly go and hit the median sacral artery. So that is how you can injure a vessel in the retroperitoneal area. Abdominal wall vessel injury, I told you how we can very easily injure any of the vessels where we are entering. In the slide where we had seen the trocar placement, all your trocars are way too close to all the vessels. Yes, you have a limited area in which you can actually place the trocars. Intestinal injuries, you can injure the gut, especially the additions. You can injure the bladder is full. So before a surgery, the bladder is usually emptied. Thank you. Very rarely at the port site that you create, although it is very small ports, uh, there can be a hernia forming after the surgery is done, and nerve injuries. So you could accidentally adrenaline. No, Anubhav, we don't use adrenaline. I said when we. I'll just go back to the slide. Over here, you see the first port that is made is the highest one. So once you enter and you see, then you do trans illumination. Is when you put the light from inside the abdominal wall, you can see it outside the vessels. You can actually see the vessels going by, and you try and make an entry into the abdominal cavity where the vessel is not there. You don't get the incision there where there is a vessel. That is how you prevent this complication number three, abdominal wall vessel injury. Uh, Intestinal injury. Now, about intestinal injury, something very interesting I'll tell you. We had a patient when I was still doing my post graduation. She was infertility, so we were planning a diagnostic laparoscopy. So before I tell her story to you, you must know what is a Verries needle. A Verries needle was developed by a surgeon called Dr. Verries, in which you put it. It's a very small needle. You put into the abdominal cavity from near the umbilicus, and you insufflate the abdomen with carbon dioxide. Yes, Parag. And once you have inflated the abdomen, then you put in your port, so the chances of injuring the bladder and the intestine are supposed to be reduced. However, this patient of mine, who I'm talking about, she had major additions of the intestine to the anterior abdominal wall. So imagine that you're trying to put in a Verries needle, but it doesn't inflate the abdomen, but instead it has entered the intestine. So this happened twice with her. Since the insufflation did not occur, we abandoned the surgery and we closed. I mean, we didn't do anything further. After 3 days, she started passing feces through the 2 times that we had actually put in the Verries needle from the umbilical port. That is when we realized that she probably had a gut injury. So we had to take her up for a laparotomy where the abdomen was opened and they found that. Did I start asking for the roll numbers? Hemant? I haven't asked for the roll numbers as yet. But we have about. I'll be teaching you for another 5 minutes. Then we can start taking in the roll numbers. So this patient had injury in the intestine at 2 points because she had abdominal tuberculosis, which had led to all the gut being attached to the anterior abdominal wall. Okay, so that is how you end up with an intestinal injury. Then incisional hernias can occur, and nerve injuries, they can occur not only in the nerve placement of the ports, but also they can occur if you are operating. So, for example, there was a surgery for chronic pelvic pain in which you did addusolysis, and you can injure the pelvic nerves in that. Now I'm coming to one more slide. This is for you. This is your future. Laparoscopy is an ever-growing field, and by the time you people start coming into clinical practice, uh, you must have heard of a concept of robotic surgery where the surgeon sits outside the room. I wish I had an image. I didn't put an image on the slide. Robotic surgery is where the surgeon sits in a portal outside the room and the robotic arms operate for him. They have an advantage over laparoscopic surgery in the amount of rotation that can occur with the instrument because it's a robot that is operating. All right, it has been found very very useful. Robotic surgery has been found extremely useful in dealing with prostatic cancers. It is not as useful in gynecological surgeries, but it is still under consideration. Many private hospitals have it. It is an expensive thing, so it is not still freely available to everybody. Now, there's something called natural orifice transluminal surgery, in which they are considering that you can put in a camera or something through the pouch of Douglas or through the rectum, and you can visualize the abdomen. Then there is a single incision laparoscopic surgery in which there is just one particular port and it has multiple entry points. So you can put in not only the camera but your other operative instruments. And through one port in the abdomen, you can do the entire surgery instead of having four ports being made in the abdominal cavity. Again, the problem with single incision laparoscopic surgery is the cost of the equipment. With time, the cost of every equipment actually goes down. So, for example, 15 years ago, radiology or getting an ultrasound done was one of the most difficult things because most hospitals had just one ultrasound or no ultrasound machines. Nowadays, you have ultrasounds everywhere. Similarly, the cost and the availability of all these instruments and procedures is going to go down. And you are this generation that will be dealing bloodless surgeries. All right. So, this I'll quickly. I have been extremely sketchy in telling you about laparoscopy because it's something that I would like to teach in detail to my postgraduate trainees and not to you. It's just an introduction. For you, it will be more like a short note. And when I was thinking about it, it is more like an introduction to how you will actually operate in the future. And I'm open to any questions. You can just type your questions in the chat. No, Hemant probably wasn't there in my class earlier. So he just put in his roll number quickly. Yes, Arun, it is available. It is being done. Transluminal Anubhav is like you put in a camera or something through the pouch of Douglas and you can visualize the entire abdomen. So you don't need to um, make a port for the lighting and all. Robotic surgery is available. Anubhav, I have not done this surgery. I have not seen it. Transluminal. Did I say that? Next time I can show a video. I don't have a video today. I'll find you a video to show in the next class. So I'm open to more questions. I can find out about natural orifice transluminal surgery. I can try and find a video for it and I can show you in the next class this video. And I'll try and show you a video of laparoscopy port entries also. So you can put in your roll numbers and you can start leaving the class. ये आने में कितनी देर लगता है मेरे पास 2 दिन बाद आता है वीडियो ये वाला
आपके पास 2 दिन बाद आया
मैं पूछ रही हूँ कि बीच में मैंने मेल चेक नहीं करी फिर मैंने आज
2-3 घंटे में आ जाना चाहिए
अच्छा
गूगल ड्राइव पे आपके म्यूट कर दूंगा
Excuse me, ma'am.
yes
Ma'am, which all procedures are available in PGI?
in PGI we are doing diagnostic laparoscopies. We are removing cysts, ovarian cysts laparoscopically. We are doing laparoscopic hysterectomies also to some extent. Myomectomy requires more expensive equipment. Suturing is difficult, so very few surgeons are doing myomectomies, but it is being done also.
Okay, thank you, ma'am.
हमारे प्रोफेशन में नहीं होता ऐसे स्टॉप कर दूं
स्किप कर दूं ये भी यहाँ पर जाना ये म्यूट कर दूं यहाँ पर